Good evening, everyone, and welcome to another edition of our NSWOCC and WOC Institute Continuing Education webinar series. This specific webinar series, titled Advanced Wound Strategies in Lower Limb Care, presented in partnership with Perfuse Medtec and geko and the Canadian Home Care Association. This is part, I want to say 5 now. It could be 6. I should have looked that up in advance. But anyways, one of many parts of our continuing series here that is bringing together Canada's leading thought leaders in wound healing to explore practical, evidence-based strategies that support better outcomes for patients living with lower limb wounds. Each webinar in the series dives into specialized topics, and today we're going to be talking about compression unraveled. And we have 2 great guest speakers with us. For those who were at our last edition of this webinar series, I believe it was last month or a couple weeks ago, you would have seen Dr. Robyn Evans and Dr. Gary Sibbald. But before I introduce them, I just want to remind everybody of a couple housekeeping notes. First things first, we're going to have a dedicated Q&A session at the end, so please do submit your questions using that Q&A tool in your Zoom toolbar rather than the chat. But in the meantime, I can see people are already doing it, but type in the chat where you're tuning in from today. I see people from Palmerston, from Vaughan, from Chatham, from Cobourg, from Nova Scotia, from Saskatchewan, from Elliott Lake, from Kingston. Awesome to see everybody from across Canada. I know we typically get a couple people internationally, so let us know where you're tuning in from. We're recording today's session, so if you haven't had a chance already to see others in the series, you can go ahead and see those on our NSWOCC.ca website. You can also watch today's, of course, back on that same page. We're also going to be sending out certificates of attendance for those who've attended the last couple recently. We are still sending out certificates of attendance. We're a little bit behind on last week, so don't worry if you haven't got yours from last week yet. They are coming, and you'll make sure to get the same certificates for this webinar later on by the end of the week. Thanks for your patience in advance there. We're also going to be using interactive polls throughout the webinar today, so keep an eye out on your Zoom screen. You might see something pop up there to answer, so make sure you click on those. So without further ado, I'm going to introduce our 2 guest speakers today. Dr. Gary Sibbald is the founder and executive director of Woundpedia and the lead of Project Echo Ontario Skin and Wound. He's a dermatologist and internist with a long-standing clinical and academic focus in wound care and is a professor of medicine and public health at the University of Toronto. Dr. Sibbald is widely recognized as an international wound care key opinion leader with more than 200 publications. He also co-founded the International Interprofessional Wound Care Course, or IIWCC, and serves as director of the Master of Science in Community Health, Prevention, and Wound Care at the Dalla Lana School of Public Health. He's also the current co-chair and co-editor-in-chief of Advances in Skin and Wound Care. We're also joined today again by Dr. Robyn Evans, who attended the University of Toronto for medical school and completed her family medicine residency and further specialized training in wound care. She's the director of the Wound Healing Clinic at Women's College Hospital, where she spent the last 15 years caring for patients with complex wounds, advancing wound care research, and supporting clinician education. She also serves on the board of Wounds Canada, is the co-director of the Wound Champion program, teaches at the University of Toronto, and contributes to the International Interprofessional Wound Care course. She also continues in her role as a full-time community family physician. We're fortunate to have both of you on with us today, so with that, I will pass over the slides to both of you. Thanks so much for being here.
Okay, Robyn, go ahead.
All right, welcome everybody, and thank you for joining us. There's a lot of people here from just about everywhere. It's a great pleasure to present tonight with Dr. Sibbald, and I would like to thank geko for supporting this educational program. Obviously, very well liked. You guys all have a thirst for knowledge, so hopefully we can fill those boots today. Next slide. All right, so just let you read through this conflict of interest, and we'll just pause here for a minute. Okay, next slide, please. All right, the objectives today to explain compression, evaluate and choose appropriate compression for each patient, be able to assess the contraindications and limitations of compression, and then apply optimal compression principles to clinical cases. Next slide.
Okay, this is our first vote. I am, and pick the highest that applies to you, paraprofessional, nurse and RPN, LPN, nurse and RN, nurse educator, advanced practice nurse, nurse practitioner, nurse NSWOCC and SWAN physician, allied health chiropodist, OTPT, etc., and then other. And if you're Voting other, please explain in the chat. So we'd like to see where the audience lies.
Alrighty, and I'll end the poll there, and I'll share the results on screen with everyone. My percentages are getting cut off a little bit because of the high attendance, but it's about our highest rate of responses comes from our nurse RNs, followed by our RPN LPNs, then our educator, advanced practice nurse, and NSWOCs, followed by SWANs, and then quite a bit of a mix of other types, including allied health and nurse practitioners and physicians.
Okay, next slide. Robyn.
Yeah, so the history, it's always interesting to know where these things come from, but things date back a long time ago, around 1600 BCE, when a medical engineer named Jobs, which I'm sure we've all heard that name, recognized the effect of just swimming in a pool, the effect it had on the legs, and the pressure that it exerted on the veins helped swelling. So he developed the first compression stockings, and it became widely used in the World War Number Two. So that's where it all started, and then it all developed after that. Next slide. So where do we go from here? So there's lots of choices for compression, and the reason we're all here today is to figure out which is the right compression for your patients. And it's really rather complicated. There's many choices and many patient factors. Next slide. All right, Dr. Sibbald's the quiz master tonight.
Which is false about compression? And the first one is it counteracts some of the effects of gravity. It is the treatment of choice for venous ulcers. Arterial disease ABPI of 0.6 would be a contraindication for compression. Enhances calf muscle pump. Classified by elastic properties, pressure, and number of layers, or can be applied with caution as part of the treatment for deep vein thrombosis. Which is false about compression?
I'll just leave it open for a couple more seconds until we get to maybe about 50% participate at least. Alrighty, I'll end the poll here and show the results. So you should see on your screen that about 46% of respondents say can be applied with caution as part of the treatment for a deep vein thrombosis. We then go to 26% saying arterial disease of ABPI of 0.6 would be a contraindication, followed by counteracts with some of the effects of gravity at 13%. 5 and 4% respectively for the last two. It is the treatment of choice and classified by elastic properties, pressure, and number of layers.
Okay, so arterial disease ABPI of 0.6 would not be a contraindication for compression. And certainly we go down to that level. It does counteract some of the effects of gravity. It is the treatment of choice for venous disease, enhances calf muscle pump, classified by elastic properties, pressure, and number of layers, and can be applied with caution in the treatment of deep vein thrombosis. What's the wrong answer, Robyn?
It's just seeing if I'm paying attention. Well, number three. So you just look at which ones are true there. Everything's true except for number three. The ABPI 0.6 would be a contraindication, is not true because that would be mixed AV disease, and we're going to talk about that a little bit more today in terms of what would be appropriate in that situation.
Yeah, so you did pretty well on that, actually. Next one.
All right, so just like with the wound bed prep, we always come back to what is the cause. And we're not going to go into a lot about what causes edema because we did cover that about a month ago. But you got to think, just a quick review here, what is the cause of edema? And I like to look at it as three things. One is the whole body's got too much water. That's shown by that sink representation on the right. Versus, is it in the pipes or the lower extremity? Is it strictly a venous lymphatic arterial problem in the lower extremity? Or is it a combination of both? And remember, when we think about the systemic causes of filling up the sink, we're mostly thinking of congestive heart failure, but also severe liver disease, where patients aren't making albumin and proper nutrients, or it's GI problems where albumin is being lost and that will cause edema. But with most things in medicine, and as people get older, a lot of our patients, we have to think of all of these things together. So remember, a good history and a good physical examination should help you elucidate what is the cause of the fluid in the lower extremity. Next slide. So this is it. This is what's really happening. There's a loss of balance between the blood vessels clearing from the veins and lymphatic system, and subsequently what happens, you get fluid accumulating in the interstitial space. And this is what you're dealing with, fluid in the interstitial space where it shouldn't be. Next slide. So when we have a healthy vein on the left, you see correct blood flow. So blood is moving through the superficial system, through the perforators, and up to the heart through the deep system, through a series of valves that open and close depending on the heart's systolic and diastolic function. During diastole, everything should relax and nothing should go backwards. However, what's happened with compromised veins, the vein will increase in size. The valve no longer closes, and so blood is flowing sort of both ways in the perforators, both ways in the superficial, and we get accumulation in places we shouldn't get. So there's a backflow of blood, and the blood and the fluid end up in the interstitial space. Okay, next slide. So this is the problem. If you look at this graph, when you're lying down, there's really no pressure in the venous system, whether your veins are healthy or not healthy. When you are a healthy person, that green line, you stand up, you move around, the pressure increases, and it increases up to close to 100 there, between 80 and 90. And then as you walk, it goes down, and it goes down significantly. Look how low that pressure goes when you're actually walking, when you have healthy veins. You're getting way down to close to when you're recumbent. And then this goes on and on. However, when you have a defective valve, your pressure goes up and it stays up. This is what we call the sustained ambulatory hypertension. The pressure in the system never goes down, and this is the problem that we're all dealing with. Next slide. Remember, an arterial assessment is absolutely required. The first question of this webinar started with this, and it's important. We need to remember what the risks are for peripheral artery disease, and the big three are smoking, diabetes, and age. But remember, arteries occur anywhere in the body, and the same ones that affect coronary artery disease will also affect peripheral artery disease or central artery disease. So hypertension, high lipids, people have had stroke, coronary artery disease. You think about this and you've got a baseline concern about arterial disease. It's also important to note that smoking is much more of a risk factor for arterial disease than it even is for coronary artery disease. And if you put it together with diabetes, it's a big problem. So any time you can spend with your patients to encourage smoking cessation, counsel, answer questions, always be open to discussion would be very helpful to your patients. Next is physical exam. Now we talk about a lot of sort of hard signs and soft signs. And I think the most important thing here is pulses. Pulses are the most reliable indicator, and that's the pulse you feel at the dorsalis pedis, which is on the medial side of the ankle, or the posterior tibial on the medial side of the ankle, and the dorsalis pedis is on the dorsum of the foot. Dependent rubor would be an important finding. The other softer findings, like hair distribution and nail distribution, you're going to note them. But if you see dependent rubor, capillary refill on a cold foot, and with no pulses, that's critically important. But any of these taken together, you'd be very concerned. But again, spend the time looking for the pulses. Now, testing. What you can do at the bedside is the audible handheld Doppler, which Dr. Sibbald will usually go through that and tell you what those sounds are. Dopplers can be either monophasic, which is not great, or multiphasic in the foot. This is quite an easy test to do. You just need the equipment and a little bit of time spent with the Doppler learning the sounds, which you can get on the internet, or you can tape Dr. Sibbald tonight because I'm sure he'll demonstrate it. And if that's a problem, or you're concerned, or you're a patient with diabetes or a lot of arterial risks, you might want to do a formal vascular assessment in the form of an ankle brachial pressure index or a toe brachial index if you're worried about calcifications in the arteries. So there's lots you can do at the bedside, and if you need to and you're concerned, there are other avenues and vascular surgeons to refer to. I'll let Dr. Sibbald talk to you a little about these monophasic and biphasic and triphasic waves.
Okay, the monophasic wave is a very muffled sound, and it's shh, 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 shh. A biphasic wave is pshh, 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 pshh. And a triphasic wave is pshh, pshh, pshh. And any multiphasic wave, if you're not sure it's biphasic, pshh, pshh, or triphasic, pshh, pshh. Well, determine that on the next slide that you have adequate blood supply to heal, and it's greater than or equals 0.9 with the audible handheld Doppler. So you can go on to do your compression. Patient can be seated in the chair. They don't have to have their calf muscle actually squeezed. It is not influenced by calcification, which a lot of persons with diabetes have calcified vessels, so you can do a toe brachial, but not an ankle brachial pressure. A palpable pulse gives you a 80 millimeters or higher pressure in the posterior tibial or dorsalis pedis. In the wrist, it's 70, and in the neck, it's about 60. The ankle brachial pressure index between 0.6, over 0.6 and less than 1.4 signifies adequate arterial circulation, but be very careful in those borderline zones between 0.6 and 0.7. And this is when you get a monophasic wave, it may be a good idea to do more vascular testing before a patient is put in high compression. You might get away with low compression, which we'll illustrate to you in a little bit. Toe pressure of greater than 30, and this is corrected by the American Heart Association, is adequate for healing. Next slide. And I think here you can have high compression between 0.9 and 1.4. Above 1.4, you've got non-compressible vessels. 0.6 to 0.9 is mixed disease, and it needs to be modified. Less than 0.6 is arterial disease predominant. You need vascular surgeon, no compression, and or greater than 1.4 calcified vessel. This is where the audible handheld Doppler waveform may help you because it will tell you where the waveforms are indicated without the calcification. So it's faster, and it certainly is accurate. And this was validated with 200 patients from the Mississauga Hospital Trillium Vascular Lab compared to what we got in our office by doing the audible Doppler. And it's about 98% accurate, but examine your patient. Is the extremity cool? Do you have dependent rubor, which becomes blanching on elevation? Does the patient suffer from claudication? I think validating any test with clinical exam is important. Don't forget your simple clinical exam. Next slide. Robyn?
All right. I'm always in all of those waveform sounds, Dr. Sibbald. So what does compression do? Well, it supports the function of those venous valves that I just explained to you how they're not working well. They're kind of letting fluid backflow. It increases the speed of blood flow and lymphatic clearance by enhancing the muscle contraction, and this is an important consideration. It reduces the leakage of fluid from the capillaries into the surrounding tissues. So the fluid doesn't even get into the tissues. And the wrap provides external support to the muscles, which can reduce inflammation and discomfort. When we think of edema, remember the fluid is going into the tissues, and that shouldn't be there. It's eliciting a sort of inflammatory reaction. And that inflammatory reaction, as you know, is painful. The swelling is painful. So by improving the edema, you're really helping your patient with pain. Next slide. So the choices are many. I think you need to be comfortable with all the systems you put on and make sure you read the product monograph. Compression can be elastic or inelastic. Elastic meaning there's a stretch to it, and inelastic meaning there's not a stretch. It's called short stretch. Number of layers, the materials it's made of. Always remember allergies and sensitivities. And my big one is ability to reuse. I mean, we have to be a little bit concerned about, daily dressings if we need to, but we need to use something reusable and think outside the box. Patient factors, there's probably a page or two list of this, but I've just dissected it down to leg shape, the amount of exudate. Pain is a big factor for compression. Vascular issues, which we've already talked about, and we'll probably mention a few more times tonight. Mobility of the patient, and pain. So stay tuned for the talk on January 21st. I'm going to talk a little bit more about pain. Next slide.
Okay, polling question 2. For low compression, I use tubing grip or a circular type of compression, edema wear, which is a longitudinal type of compression with about 80% of the surface open. Do you use both tubing grip and edema wear? None of the above, or instead occasional single layer elastic bandage. And if it's other, please put that in the chat.
Awesome. I'll leave it open for a couple more seconds while I'm doing that. Just a reminder, if anyone has questions for either of the presenters, use that Q&A button in your Zoom toolbar, and that'll make sure we can get to as many as possible during that Q&A portion at the end. Alrighty, I'm gonna show the results now in front of you, and it looks like about 50% on the dot are saying tubing grip, 20% for both edema wear and 20% as well for tubing grip and edema wear. And then 5% for none of the above, 5% occasional single layer elastic bandage, 1% for other. Yeah.
Okay, and I think this is important. So what we want to do out of this vote is to demonstrate both the tubing grip and the edema wear. And this is Pat Coots, and this is part of the Echo Skills video series. So let's listen.
The first piece of compression that we're going to talk about is a circular elastic bandage. One of the trade names is tubing grip. It will, when it's doubled, will give a light compression of between 10 and 15 millimeters of mercury. There is a chart that does tell you how to how to measure the leg and fit the tubing grip. What you do is measure the largest part of the calf of the leg with a tape measure. And record that in centimeters, and according to the chart, it will tell you which of the sizes of the product is the best one for you to use to get your compression that you wish. To measure this to get the appropriate length, you need to actually start your measurement 2 fingers below the knee, giving some slack to the tube to the base of the toes. So take this and measure the slack to the base of the toes, and this is where you want to cut it. Keeping in mind that this product does contain cotton, so it needs to be cut a little longer on the for the first piece. It will shrink when you wash it. It is meant to be used on a one-time basis, but it can be washed a couple of times to be used. There are several ways to put this on. One of the ways is to use a plastic bag and put it over the foot. Put it on. For this particular leg, it measures for a size F, and holding the tube in place, removing the plastic bag. The other way to put this on is to take it, hold it back on itself so that there's enough room to insert the foot, put it on over the foot, and up over the leg. Okay. The next piece of compression that we're going to look at today is something called edema wear. It differs from Tubi grip in that instead of the compression being applied in a circular motion, it's applied in a longitudinal motion. It comes in varying sizes, and the leg again needs to be measured. To determine the size that one needs, again, one measures the largest part of the limb at the calf, and because it's made in the US, it comes in, it's measured in inches, so you need to be careful when you're measuring this and not measuring it in centimeters. So this leg that I've measured measures 13 inches, so it would have a small edema wear. There is a blue line in the edema wear. This is meant to be moved around with each application, because when you stretch this, you can see that the longitudinal wales, these are what provide the compression. As you move this blue line around, you then get the compression between where the wales are. There are a couple of ways of applying this as well. One of them is to stretch it out. The other thing I should say is it doesn't matter whether the blue line is at the front of the leg, the back of the leg, the side of the leg. But if you stretch it out before you apply it, stretch it out, turn it back on itself so that there's enough for the foot. And put it on. One of the issues with this is that it will tend to slip on people, and it is recommended by the manufacturer that you put a 2 to 3 inch cuff at the top of the leg, and that will help with the slippage. The other way that you can do this, which is easier for people who, if it's an older person who is applying this, and they have a bit of problems with their fingers, because this does require some dexterity with your fingers. If they're having problems, if they use a plastic bag and put it over the foot and apply the edema wear over it. Again, pull it up so that you've got enough to put a 2 to 3 inch cuff at the top of it to prevent the slippage. Hold on to the product and remove the plastic bag. The other piece with this one of the pitfalls with using the edema wear is that the top of it will roll with use. And by simply trimming off the roll, it will help to give you a longer life for this. These are designed, if they're looked after as they should be, to last anywhere between 3 and 6 months. So they don't have to be replaced as often as some of the other types of lower compression bandaging that we have.
Okay, and I think that pain is often a reason to start with low compression, as is a lot of edema. On the next slide, there is a difference between short stretch and long stretch. And long stretch will stretch about twice the diameter of what you start with. A short stretch only stretches a small amount. So a short stretch is mostly inelastic. A long stretch is elastic energy. And when you go to the stopping distance of a long stretch bandage, you should apply it halfway between the relaxed state and the stopping distance. And therefore, you're getting the most elastic energy in both directions, whether it's stretched or it's contracted slightly. Next slide. Unapaced boot usually aggravates stasis dermatitis, is useful for edema below the malleolus and balloon foot, has high pressure at rest. Answer 1, 2, or 3, or answers all 1, 2, and 3, or 2 and 3 combined, or 1 and 3. Enter and sign in, please. You know, this boot has withstood the hands of time, and it was invented by a German dermatologist in 1895, and it's still used today, which, you know, really says something about its utility. And it's been improved in terms of pre-made zinc incorporated into the boot and using something to increase the structural integrity for a longer period of time. So let's have a look.
Perfect. So you should see that 49% say answers 2 and 3, 25% say 1, 1, 2, and 3, 10% say just answers 1 and 3, and 8% for is useful for edema below the malleolus and balloon foot.
It really is, and zinc is very soothing. And before we had topical steroids, it really doesn't aggravate stasis dermatitis. It actually makes it better. It is useful for edema below the malleolus and balloon foot and has high pressure at rest. So if we're looking at this, 2 and 3 are correct. Number 5, you did very well, 59 out of 120 or 49%. Good for you. Let's look at the on a boot and let's go back and have Pat explain this again. And I think it is important that if you learn the technique for somebody with a lot of swelling below the malleolus, a balloon foot, a lot of pain, stasis dermatitis, those patients do very well in this boot. Let's have a look.
We will now demonstrate the application of zinc impregnated gauze bandage, trade name Viscopaste. You may have heard of this by it referred to as an Uniboot. This bandage works very well for people who have problems tolerating the other types of compression bandage. It happens to be very cool. I tend to use it a lot in the summertime. So it comes with a starter tape. And again, as with all compression bandaging, you start at the base of the toes. Two things. You need to ask the patient to flex their foot as much as they can so that you get a 90-degree flex of the ankle. And the second thing is that you need to warn them that this will be cool when you apply it, even cold, so they are prepared. Again, starting at the base of the toe, wrapping around, doing a figure 8 over the ankle. You need to include all of the heel, so you may need to go over the ankle a second time. As you go up the leg, you can put this on in two ways, but it's again important to read the manufacturer's instructions. You can fan fold it by bringing the bandage back on itself and making a pleat, 50% overlap. There is no stretch with this, you simply lay it on the leg. The other way of doing it is to bring the bandage to the shin and then fold it back on itself. Folding it back on itself and bring it around so that it meets in the center and taking it around again. To prevent this viscophase from leaching out onto shoes and onto the floor and the carpet, you would want to wrap that with cling. Again, just wrapping it in a spiral. And then you need to put something on this to hold it in place. We will use a cohesive bandage. Again, asking the individual to hold their foot at a 90-degree angle or as much flexion as they can get. When you add the cohesive bandage, you then get what is known as a modified Unravelled or a Duke boot. Cut your cohesive bandage and roll. And don't touch the cohesive bandage with zinc or it will not stick.
Okay, I think that this illustrates a technique that has withstood the hands of time. It's comfortable for patients, and because there is not elastic energy involved in this, you have a low pressure at rest. So patients with painful or very swollen legs, especially the balloon foot, or because it's got the heel included, it's very useful for balloon foot, and because it is a short stretch type of bandage. Next slide. Okay, Robyn.
Okay, this is just saying the same thing in a more graphic representation. So this is showing you the pressures. If you look at this blue line, which is short stretch, you can see dorsiflexion and supine. The pressure is up around 80 millimeters of mercury and drops down significantly, walking and standing, spikes up again, as opposed to the long stretch where you're not seeing a lot of change. It starts at a certain pressure and it's mostly maintained with little tiny spikes just going up to 60. So you can see that with the short stretch, you're getting a lot of change to the pressure with it going up significantly and dropping down. And it's this rest pressure that patients with mixed AV disease, you're only seeing high pressures on movement, but on rest, that pressure is dropping down again. Then this is why the short stretch seems to work so well for patients that have comorbid problems such as pain. Next slide.
Okay, and when we talk about Laplace's law, we look at subbandage pressure. And in the numerator, when tension increases, when more layers are added, and when the circumference is thinner. In the denominator, a tension times number of layers times a constant, you've got a larger leg circumference will decrease pressure, as well a wider bandage. And the key point is wide bandage, lower pressure, narrow bandage, higher pressure. multiple layers. If you like, when you're looking at tension and you're looking at constant, you have to remember that some of these layers are actually layers that are conforming layers or protective layers. And so you have to be very careful as to what's compression, what's going to increase the tension if it's elastic, or if it's a retention bandage. It's really protecting the leg from high pressures. Next slide. Okay, Coban 2 and is more inelastic than elastic. This is a flexible cohesive bandage. Has only one of two layers around the heel. May be associated with miliaria or a heat rash. In the summer months, it's answers 1, 2, and 3. Answers 2 and 3 are answers 1 and 3.
Wait a couple more seconds. Been getting lots of great questions in the background here. Getting excited for that. If you have a question, use that Q&A button in your Zoom toolbar. Alrighty, couple more seconds here. Awesome, and we're about 50% responded now, so I'll share the results on screen. You'll see that the highest responses was for all of 1, 2, and 3 at 38%. 29% of responses answered just 2 and 3. 22 said answers 1 and 3, and only 5% and 4% for the first two options, respectively.
Okay, 1, 2, and 3 are correct. It is more inelastic than elastic. It only has one of two areas around the heel, and it may be associated with miliaria or heat rash in the summer months because the first layer is a foam layer, and that does help to concentrate the heat. Okay, let's let Sunita guide us through this portion.
We're going to be demonstrating Coban 2, which is a short stretch inelastic system. It comes in a kit as 2 layers of bandages, and as you can see, the bandages are numbered 1 and 2. So as with all compression systems, you always start at the base of the 5th toe. Make sure that the patient has the ankle flexed at a 90-degree angle. We call it the toes to nose. With this particular compression system, we usually leave the ankle exposed. And at this point, we cut off the bandage. Now, this is designed to stick to itself, so you generally don't need to use tape. And you just start where you left off. You follow the roll as you unravel the roll. And as with all compression systems, you generally end about 2 fingers below the knee. And you cut off any excess because you want to avoid the tourniquet effect at the top. Now this is the second layer. And as you can see, again, there's minimal stretch to this layer. So you apply this as snugly as possible, and you do a figure 8 of 8 around the ankle. And with this particular layer, you cover the heel. And you follow the roll as you go up the leg. you have a very skinny leg, ensure that you are padding any bony prominences prior to application of the compression system. And all you have to do to get it to stick is just roll your remaining roll onto the area that you cut. This bandage system comes with an elastic stocking, and this just helps prevent the static and from the patient's leg sticking to the sheets at night. This compression system is designed to be changed anywhere from 3 times a week and can be left on up to a week depending on the amount of exudate.
So you've had your bandage on for 3 days, and I'm hoping that you didn't find it too uncomfortable. We would like to remove the bandage now, taking the stocking off. The easiest way to take the bandage off is to cut it off with using a pair of bandage scissors. These happen to be a very heavy pair of scissors. You can get them that they are smaller, but they really do need to have the nubbin on the end so that you don't damage the skin as you're cutting it off. Taking the scissors and knowing where the wound is, being sure to avoid that wound area, and just cutting through gently. You can cut through both layers of the bandage. The tricky part might be just around the ankle where you have more excess bandage. Being careful when you're going up the leg. Because of the nubbin on the end of the scissors, it will slide very easily up underneath the bandage, and your bandage is off.
Okay, so we have looked at Coban 2, and you did notice that the first layer does not go around the heel. Watch for the balloon foot. It is more inelastic than elastic, and we have got away in many ways from the 4-layer bandage. Next slide. Robyn.
Yeah. All right, that was a good demonstration, and I especially like that rolling of the Coban over the final product to get it all stick together. I've never seen that before, so you learn something all the time. So what is our absolute contraindication? Well, severe peripheral artery disease we've alluded to throughout this talk, and anything less with an ABPI of 0.6 would be very concerning. But you might have a sense that you're dealing with something that is really peripheral artery disease in addition to venous disease. Again, looking for those signs of dependent rubor, cold foot. The history may bother you a lot in a smoker with coronary artery disease and a swollen foot with dependent rubor. So think about all of these things. Severe cardiac insufficiency is probably one that you will come across. That means that if you have swelling in both of your legs as a result of the whole body having too much water, and you try to send more fluid back up the hill to the heart, you can actually exacerbate cardiac insufficiency and worsen cardiac pulmonary failure. So there is no guidelines about doing this. If you're worried, speak to a physician or the cardiologist. If it's mild and you're just worried a little bit, I always err on the side of you going light and doing one leg and see how it works, and then in 2 weeks do the other leg and see how things are. But there's really no specific guidelines for this. And of course, allergy to materials such as latex would be an absolute contraindication. But more of what we see are the patient-specific factors where we're trying to navigate pain, intolerances, preconceived ideas about compression, unusually shaped legs, an ankle diameter less than 18, where you're going to get significant pressure because of Laplace's law, or very fragile skin. We worry about neuropathy, pressure points, watching tendons. Also the ability to get the compression applied appropriately. Do we have a lot of lipodermatosclerosis, maybe harder to compress? And then, as Dr. Sibbald talked about, edema below the malleolus, it's really hard to get rid of that. So these are all the things we sort of encounter the real no-nos and you got to watch it kind of things. Next slide. So a lot of complications can occur. This is a patient of mine, and you wonder how this can happen, but it really can. Patient obviously had a lot of pain, but it wasn't applied appropriately. The compression, patients developed a lot of maceration to the skin. And, if this person had any element of arterial disease, it would be a devastating problem. Next slide. Now, this one represents a difficult problem, and even with the best wrapper in town, this might be a tough leg to wrap. So we always have to think of what else we can do. And in wounds, I think you're always challenged with different shapes, body contours, not just legs, but everywhere else we work, things that are appealing to the patients, but lots of things in the toolbox. So next slide. More of the same. Again, issues with compression, damaging the patient, not being put on correctly. So next slide, Andrew. So we looked to other options for managing edema. And I don't know if anyone's had the opportunity to look at this study, which is a well-done study looking at the impact of healing in venous leg ulcers with something more novel. Next slide. And I know Dr. Sibbald wants to talk about this, so maybe I'll let him get going on it and I'll fill in later.
Okay, so the original study using geko used a primary endpoint of the rate of advance of the wound edge. And there were a number of secondary endpoints and a run-in phase with visual analog scale for pain at days 0, 7, 14, 21, and 28. And a little bit of self-control eliminates intergroup heterogeneity. But on the next slide, the run-in phase was 4 weeks, and the standard of care was for all patients. And at week 4, if wounds weren't healing at the expected rate, the treatment phase really represented either continuing compression alone, which is the standard of care, or the neuromuscular stimulator, which is the geko device. And what happened was that this actually doubled the healing rate. And what's even more interesting is at week 8, and the rate was doubled, but even though the geko was discontinued at that time, at week 12 and week 16, the doubling healing rate continued. And flux studies, next slide, really showed that the circulation locally was over 200 times greater and around the actual wound and many times greater in the whole gaiter area. So what you see is with the standard of care, a very slow process of healing of a venous ulcer, and the standard of care with the neuromuscular stimulator, 12 hours each day, you see almost complete healing at week 8, between week 4 and week 8. Next slide.
I'd just like to say one thing, Dr. Sibbald.
Yep.
The interesting thing about this slide, everybody, is that it's a small number of people, but it can be a small number of people because it's self-controlled. So we don't get that heterogeneity, as well as the fact is we're not looking for total healing. We're looking for rate of advancement of the wound margin. So it's an excellent way to see an effect very quickly. Okay.
All right. And what does the muscle pump activator work, or the geko work? With poor local blood supply, and sometimes it's edema, sometimes it's inflammation, or sometimes it's woody fibrosis. And with the woody fibrosis and fibrin deposits, you really get relative ischemia with venous disease. And the geko, even without compression, will improve venous return and reduce swelling. And there are some studies that you've seen previously, if you've been in some of these sessions, whereby post-renal or renal and pancreas transplants, this did much better than using thromboembolic stockings or using a device to try and increase venous return. In previous published study, there is improvement in venous arterial and microcirculation, accelerated healing rates, reduction in ulcer size, and the device is well tolerated by patients. And it creates a twitch response from the ankle, and it's that twitch response which activates the muscle. And there are some theories now that this muscle activation may actually work like somebody who's training and really reducing ischemia. And we have even in some individual patients looking at arterial damage in the foot actually showed some increase in local circulation from vascular lab studies in the audible handheld Doppler. Next slide. Robyn, go ahead.
Okay, so I mean, we need to remember the basics as well. So remember about education and reminders are necessary. Lots of studies shows that patients don't get it necessarily the first time. So you're not wasting your time by, going over swelling, edema, care of all these products, use of the products, little things like put the compression on first thing in the morning before the foot or leg has a time to swell. All of these things need to be reminded regularly. Elevate the leg. Anybody with even compression who's standing for prolonged periods of time all day, still, you need help by leg elevation, as you saw in those earlier slides, how when you lie down, the pressure in those venous systems reduces to almost zero. Appropriate footwear. This is a pet peeve of mine. There's no way you can walk and dorsiflex your foot if you're in flip-flops. I don't know, as a family doctor, I see people come in September wondering why they got swelling in the ankles because they've been wearing flip-flops all summer in the heat. So you have to have an enclosed shoe that you can actually activate the calf muscle pump. And of course, care of the skin. We don't want any breakages because that's a source of bacteria and infection. So all of these things, just another few things for you guys to remember at the bedside, but well worth your time. Next slide. Dr. Sibbald, you want to end it up?
Okay, so the take-home message: assess the cause of the swelling, history, and physical. Consider options for compression, keeping in mind patient-centered issues. Identify the absolute contraindication with specific attention to arterial compromise, history, and physical. Evaluate compression evidence, but it's not always effective for many reasons. And the patient may have comorbidities. There may be infection you haven't treated. You may have the wrong diagnosis. Explore other options, evidence for the muscle pump activator. And I think that what this is telling us is that we do have another device that may act as a stimulator to healing in leg ulcers, and it looks like using it earlier on in the course of the journey may actually save healthcare system money and improve patient outcomes. I noticed, Robyn, there are some questions in the chat that, and Jeff has encouraged further questions, but the reference for the multiphasic pulse equal the ABPI greater than or equal 0.9 is Alavi, Sibbald et al. It's in circulation. And if you Google Alavi and the audible handheld Doppler, that will definitely come up. Client complains of vertigo. Can I perform an ABPI in the chair? No, but you can do an audible Doppler. What are your thoughts on systolic toe pressures for determining circulatory status? I think it's a little more difficult to do, but it's not altered by calcification because the artery is small enough. It doesn't get circumferential. Robyn, are there any there you want to tackle, or Troy, do you want to?
If you want, I've been kind of grouping them as I went here. I think we
Go
broke a
for it.
record for the most number of questions, so I'll see if I can kind of, you answered a couple there too. Let's go from here. Can you just explain once more what dependent rubor is and how clinicians can recognize that over the bed?
Okay, it's red. It's much more difficult to recognize in persons of color, and you get a dusky color. And that's because the arterial circulation, trying to work against gravity, is pooled in the foot. When you raise it, you get a drainage because the gravity effect's gone and it goes white. So that's the blanching on elevation. Make sure it's a cool foot. Ask them about claudication.
And remember, if it
Perfect.
doesn't change color, you might be looking at something like a cellulitis. So the red foot is kind of got a few different things to it, but dependent brubar can be anywhere in the foot. It could just be even just the toe.
And we had a just general question like that as well about safe compression decision making. Could you comment on the use of the compression in the context of cellulitis, if it's safe, how it should be adopted, and also whether infection might be a contraindication for compression?
That's not so difficult. I mean, you should use something that you can take off or slide down so that you can see what's going on. But putting a line around, Robyn, and you can answer this too, around the top and the bottom of the red area and watching to see with treatment that that gets less. I mean, you need cultures, you sometimes need IV antibiotics, but the Oviva study in the New England Journal showed that for many, oral antibiotics will equal IV antibiotics, even for osteomyelitis, but sometimes we use an increased dose. Robyn?
Yeah, no, that's all correct. I think you have to think about pain with cellulitis, so you might have to go a little bit lighter than you'd want to. And again, a reusable something because you should probably look at it every day. So those are my 2 cents.
And I think this was the next one on the list. You might have already seen this, Dr. Sibbald, but uh, it was about here if you're unable to obliterate pulses when doing an ABPI, but you are able to hear a multiphasic waveform with palpable pulse and warm legs. Can low compression be used until vascular assessment can be done?
Well, I think if you get a biphasic pulse, we go immediately to compression. And, there are more legs that are accessible with the audible Doppler. And if you're not sure, you can record it on your cell phone. It's an MP3 type of storage, and you can send that and get verification. So I think yes, and that's the whole purpose behind the audible Doppler, the oral antibiotics, and cheap and cheerful plantar pressure redistribution that we can have patients actually treated in their home community. Robyn, comments?
No, I think you covered it there. I mean, you do have to be cautious. Don't just go on numbers. Do the physical exam. See if you feel the pulses that are present. I work with Dr. Casey, and his biggest thing, can you feel the pulses? If you can feel the pulses, that is a very good clinical sign, and then you can add the waveforms to have a look and listen.
Yeah, the problem with the palpable pulses is you can't record it or verify
Hmm.
it
Oh, but
externally, which is what leads to some of the problems within the home care system. And yes, you can put an boot on top of other dressings. Yes, you can use it for lymphedema. And I think that it's really important that the boot is underutilized. And I think early in my career, I underutilized it as we were all tied up in 4-layer bandages and everything. And Robyn, I think the hands of time has really taught me that the boot is a useful modality, but it's got to be applied properly.
absolutely. But there's a question here saying, our vascular surgeons order Coban 2 or Coban 2 Light with the Viscopace? Now, this is not ideal because that would give you too much compression. You should never use a system outside what it was intended to use. So if you're using Coban 2, you should just stick with those 2 layers. If you're using Viscopace, that's a different system.
And don't put Coban 2 on top of Visco paste. You've got to use the original Coban, the flexible cohesive bandage. And when you stretch them, they are quite different in physical properties. And sometimes using a thing called Easy Fix is even lighter and can help people secure an boot.
And could visco or should visco paste be used when excess drainage is present?
Sometimes under it, you can use a super absorbent. It's probably decreasing the compression, but it helps. But with the increased drainage, make sure you know the cause. Is it infection? Is it other systemic factors? And I think most common, and Robyn, you and I have been through this before, congestive heart failure, liver and kidney disease, anemia.
Yeah, and remember, if you're going to use, if there's so much oxidate, you have to change it every day. You're probably better to use a reusable system
Yeah.
short term.
Yeah, so thank you for touching on that. I know it's been a discussion in the chat about whether visco pays can or cannot be paired with
No,
Coban's compressive layers. So thank
no,
you
it's
for
big
clarifying
talk.
that. Yeah, had lots
And
of
when
questions
we
on that.
measured that, Troy, it gave pressures of over 80 millimeters of mercury, way too high. You're
Yeah.
going to get balloon foot, you're going to get increased pain, you may even cause new breakdown.
Yeah.
So a couple other questions about, let's go with these ABPI questions. Someone was asking whether ABPI is required before applying mild elastic supports like Tubi grip.
No. We do it, but it depends on your system and your local healthcare rules. But we have not done an ABPI in our clinic in 10 years, ever since we did the study on the audible handheld Doppler and realized how superior it was in the clinical setting. And I think that the sequential lower leg arterial Doppler is the next step if it's monophasic. And there might be some monophasic ones where, you've got a pressure or you've got an ABPI of 0.6 or zero point 0.7 and zero point 0.8, and you could have done compression. But the vast majority of patients were able to determine that they can have compression and don't have vascular disease. It rules out vascular disease, but look at that 200 patient actual publication in vascular. Troy, that's freely available. Maybe we could put the reference in the chat, or Andrew. Andrew will
Or
put it in
Andrew,
the chat.
if you're able to put in the chat, or Andrew, if you email me, I can put it in the post-webinar email that you're going to get with your certificate, so you can take a look at it after too. Just to clarify, and I've got a couple just double checking here. So some people are saying, correct us if we're wrong, no visco paste under Coban, regardless of using a Una boot or not.
That's correct. It's Coban 2. You can use the original Coban, but not the Coban 2 or the Coban 2 Lite. The Coban 2 and the Coban 2 Lite are different than the original flexible cohesive bandage, which I believe has a green inside on the actual roll.
I think the misunderstanding stood when we switched to Coban, and I had a problem teaching residents too. There's Coban 2 systems, and then there's a self-adherent wrap that was also called Coban. And I think a lot of people just jumped on the bandwagon and just started using it over Viscopaste. But I was with Pat Coots in Dr. Sibbald's office when we looked at the pressure studies of how much pressure you're getting with this, and it is inordinate. So don't do it. It's a lot.
Thank you. And I'll ask a couple questions related to gecko here. I know we've got a few coming up. I know Jeff behind the scenes here has been answering some, but can you answer, because it was a part of the series earlier, is arterial compromise or peripheral artery disease contraindicated for gecko?
No, no, we think that actually it's improving blood flow. So, so long as you can get the gecko on the peroneal nerve and get the twitch, it's usually effective. I actually just put it on a patient last week with, not able to revascularize a leg with severe pain, can't tolerate compression, and I just put some gecko on her, and I'm hoping for the best. Fingers crossed.
And another question came up about whether gecko should be used instead of compression, or is it intended to be used in collaboration with compression therapy?
Well, it's meant to be used in collaboration with compression if all things were perfect, but sometimes people can't tolerate it for many different reasons. So sometimes it's used on its own.
Yeah, there's an interesting question about the Tubi Grip measuring guide says that Tubi Grip's supposed to be double layer for this bandage pressure to match what's in the table. The video starts with single layer. Yes, you can use double layer, but it's what the patient can tolerate. And when you're starting out, you may find, and there are some patients that only tolerate a single layer. And there are two ways of putting a double layer on, but Keith Harding went up to 4 layers, but each of the tops of the layers were at a different level in the leg, and you gradually do it. But sometimes for patients that don't tolerate anything, we do routinely start, and Keith Harding did, when he did the original studies, did start with 1. No, you're not measuring the same pressure that you might get the bandage pressure, but sometimes 1 layer is only what the patient will tolerate, and sometimes you have to start with 1 layer before they're willing to build up. And one of the biggest comments I get is I took the compression off because it was cutting off my circulation. And my answer to that is the only good wrinkles in life are the wrinkles under a compression bandage because it shows it's working.
Well, what I'm gonna do, I know we're getting about 10 minutes past time here. We've got lots of great questions. A lot of them are specifically about Coban, they're about Tubi Grip, etc. So I'm gonna echo what Karen mentioned here is that Solventum, or just that some of these questions might be better off for those brands themselves or those companies, and I'm sure we will. You'll have opportunities to speak to them at another time too. As we start to close today, I want to remind everyone that we do have a number of webinars coming up in this series still. The next one's going to be coming up on December 2nd, and that's on dermatological pearls. We have another one on December 8th. We will return back in 2026 with a full list of webinars that are going to go from January to June, also a part of this same series too. We have some save the dates put up on our website. So as I said, they go from January all the way into the end of the first half of the year. So do take a look at that. We're going to be sending the recording for today as well as the certificates of attendance in the next few days. We're going to get it for sure by the end of the week, but just give us a couple days as we're completing the backlog from some other certificates of attendance too. And thanks for your patience in advance. But Dr. Evans, Dr. Sibbald, I think Dr. Evans, this is the last one, a part of the series for you. I could be wrong, but I want to say thank you. If you have one more in the series, we look forward to seeing you then. But either way, we appreciate both of you for sharing your expertise and your wisdom and starting some great discussions with us here too. So we look forward to seeing you on another webinar. If it's not before 2026, it'll definitely be in 2026. And Dr. Sibbald, I think you might have you wanted to say something?
Yeah, just a final comment. If you want to look
Yeah.
at the waveforms and integrating it into practice, Wound Bed Prep 2021 and Wound Bed Prep 2024, Delphi Consensus, are available free of charge online. So if you Google that, I'm the first author on the 2021, and Hiskey Smart, along with 40 others, are the authors on the consensus in 2024 for low resource communities. And in that, it does give the background for the audible handheld Doppler and the references. It leads you to the references that accompany why we're using it and how it was validated.
Thank you. And I just saw Dr. Evans, you'll be on January 21st, you'll be with us for pain management for wounds. Dr. Sibbald, you'll be with us at the next one on Tuesday, December 2nd. So if you want to hear more from both of them, or if you have further questions, do go ahead and register. You can register up until January right now, and I'm going to be sending out the link to register for future dates in 2026 soon. With that said, thanks again to Perfuse Medtec and Geko for helping make this webinar series possible, and we look forward to seeing you at the next one.
Thanks, everybody.
Thank you. Have a good day.